So, hello and welcome to this ARMA webinar on IAPT and psychological support for people with musculoskeletal conditions. My name's Sue Brown and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA. We're an umbrella body that brings together patient and professional groups to work for better health services for people with musculoskeletal conditions of any kind. Before we get started, we're just going to find out who we've actually got on the line today. So I've launched a poll for those who are able to see it. And if you could just answer the questions about what's your main role and where do you work? And then in a moment, we will be able to see who we have joining us today. The reason we're doing this webinar is that a few months ago, we held a roundtable on mental health and musculoskeletal conditions. It's a really important issue because people with musculoskeletal conditions have a much higher rate of depression and anxiety than the general population. And we need a really much better integrated approach to supporting people's physical and mental health. And we really see IAPT as one of the ways in which we can help to do that. So I'm just going to end that polling and share the results so we can see that we've got quite a range of people here. We've got quite a lot of commissioners. AHPs is the largest group, psychologists, service managers, a whole range. Most of you work in physical health services, but a fair number in mental health services and also quite a number in integrated physical and mental health services, so that's great. So I'm just going to stop sharing that. And then today we're going to hear, first of all, we're going to hear a brief overview about the IAPT programme from Ursula James, who's the Senior Clinical Delivery Manager for IAPT at NHS England and Improvement. And then we're going to hear from a couple of places that have implemented IAPT in this way about their experiences and what they've learned. So I'm just going to hand over now to Ursula, if you want to share your slides.
Thank you. Thanks very much. And thank you to everybody for joining today. I'm just going to share my slides with you. Let's see, is that working for everybody?
It will in a second.
Can everybody see those slides?
See that you've started screen sharing, and there they go, yes.
Lovely, brilliant. So I'm going to talk a little bit about IAPT so far and what IAPT services were set up to achieve in the early days. We've been going now for 11 years, and IAPT were improving access to psychological therapy services. And it has completely transformed the treatment of anxiety and depression for people with common mental health disorders. Previously, it was very hit and miss whether people with common mental health disorders were able to access any treatment locally. It really depended very much on whether your GP had in-surgery counsellors working. So the plan was that there would be these stepped care psychological therapy services that were established across every area of England, that they were self-referral. And what we've seen coming from that over the past 11 years is that the rates of people being referred and being treated in IAPT have increased year on year. So in 2018-19, which is the most recent data that we have, over 1.6 million people were referred to IAPT services. Now, because they are self-referral, a number of people who self-refer to the services or get referred by their GP or other health professional won't be appropriate for treatment in IAPT and may need referring elsewhere or may not want to engage in IAPT treatment. But over 1.09 million people entered treatment in 18-19. IAPT is very unusual because it collects a very large data set on everybody that comes into IAPT services. And it was one of the first mental health services to record outcomes. And we're now at 98% of cases where we've got outcomes on whether people recover, how well they do, whether they improve. It's a massive change in delivery of mental health care. Before IAPT, we only had outcomes recorded in around 38% of people who were receiving treatment. The recovery criteria for IAPT is very strict. It is even more strict than randomized controlled trials, because people are expected to drop below a certain measure on the PHQ-9, which is a measure for depression, and the GAD-7, which is a measure for anxiety or other anxiety-specific disorder measures. So it's quite a high bar that we've set for IAPT services for people to recover, but nationally 52% do, and a further 16% improve. That's that their scores drop significantly from where they started. And 7 out of 10 CCGs have recovery rates over 50% currently, and some are over 60%, which is really fantastic news. So to talk a little bit about how big IAPT has got, so Simon Wesley was reported as saying it was the greatest revolution in British mental health in 50 years. We've had reports from all over the world of other countries who are developing IAPT. These include Denmark, Sweden, the USA, Canada, Australia. And the New York Times feature back in 2017 described it as the world's most ambitious effort to treat depression, anxiety, and other common mental illnesses. So in 2015, it was the start of thinking about the plans for the 5-year forward view, which started in 2016-17. And it was devised that an increase of access should be brought about in IAPT services by the development of what we called integrated IAPT services. And 2/3 of the expansion, so initially in 2015, the target for access to IAPT was 15% of prevalence of common mental health disorders. We've moved now to 25% by 2020, and recent developments in the long-term plan have increased the access even further. But 2/3 of that expansion in the 5-year forward view period was expected to be delivered by integrated IAPT services. These were services that were intended to be integrated with physical health pathways for people with long-term conditions or distressing and persistent medically unexplained symptoms. The first 2 years of the 5-year forward view, 16-17 and 17-18, we had a number of early implementer sites. There were 68 CCGs across the country who were delivering IAPT LTC services, and they were very closely monitored. We looked at the conditions that they were seeing, the outcomes they were getting, the integration levels they were achieving, and how it was actually working on the ground. From last year, we expected, which was year 3 of the 5-year forward view, we were expecting all CCGs to commission IAPT LTC services across the country in their local areas. Now, we weren't able to dictate which conditions each IAPT service develops their IAPT LTC integrated offer in, but we expect them to be looking at their local need and prevalence and the services that they have locally, and working with those systems to develop these integrated pathways. And so why were we doing this? Really, we knew that people who had long-term conditions were already being seen in IAPT services. they were given the core IAPT offer. It was never a diagnosis of exclusion, but they've been underrepresented. If we look at the national prevalence for long-term conditions, they weren't coming into core IAPT at the same rate that we would expect to see them. And we know there's a lot of literature, and I've listed an example there, that treating mental health problems actually reduces the cost of physical health care. We've got an example locally of Hillingdon and their COPD trial. And we know that the best outcomes are achieved when you adapt the treatment for the specific issues and embed it in a pathway that's integrated with other services that are involved in delivering the care for that person. So it needs to be integrated, it needs to be offering treatments that are adapted to that particular person, and it needs to be a personalised approach. In order to do this, we knew that we needed to train the current IAPT workforce, and we developed some top-up training for both levels of practitioners. So we're a stepped care model in IAPT. We deliver step 2 treatments by psychological wellbeing practitioners, and we deliver step 3 treatment by high-intensity therapists who are trained in a range of modalities. And we knew in order to deliver this integrated care, specifically for people with long-term conditions, that those therapists would need some top-up training, not so they became the expert in the physical health condition that they were treating, but so that they could adapt the treatment to work for the needs of that client. And I've put some quotes on the screen from people who've gone through that training and the impact that it's made to the delivery of their treatment for people with mental health conditions. And feedback that we've had from a few services that I've put up there, and the hospitals and from GPs, has been that certainly from the early integrator period, we found that this has been welcomed by physical health colleagues. We've had some teething problems in some areas, but certainly the providers and service users have said that they found this development really good. And I know that we need to very much improve on the offers that are out there and do more work in this space. But it certainly, from our point of view, seems to be a really good start.
That's great. Thank you very much, Ursula. That's a good introduction to the programme. But we're now going to talk about a couple of examples of where this has been put into practice. So I'm going to start by asking John Pym to share the experiences of Buckinghamshire.
Okay, I'm just going to get my slides to share first.
And I can see we're starting to get some questions coming in. We are going to do all the presentations first and then come to questions. But we will come back to those once the 3 presenters have presented.
Okay, can you see those okay?
Yep, that's looking good.
Okay, thank you. So if I just start with explaining who I am. I'm John Pym. I'm a clinical psychologist, and I have been working in IAPT since the beginning 11 years ago, and I'm the clinical lead for the Buckinghamshire IAPT service. By coincidence, though, my previous job was working in clinical health psychology, and I set up the Buckinghamshire Pain and Fatigue Management Services. And I've continued to work in both services. So I'm coming at this from the perspective of somebody who has both works in IAPT and also works in physical health services. Ursula gave us a really good explanation about the background to the early implementer programs for IAPT long-term conditions services. And Buckinghamshire was one of those IAPT early implementer services. And one of the areas that we chose to work on was looking at MSK and pain. But I've also listed here some of the other services that chose to work on that as well. We don't know whether or not these services are still doing this in terms of the detail, or whether there are far more people doing MSK and pain at the moment, because at present the early implementers are the only IAPT services that submit specific data related to the long-term conditions programs that they run, where you can actually see the results of particular measures related to long-term conditions. But IAPT is shortly to bring in a new data set, minimum data set 2, in the new financial year, at which point we'll be able to see this data for all IAPT services across the country. And we're hoping that a recent NHS benchmarking exercise, which has collected information from IAPT services about what they're doing currently, will also tell us something about which pathways IAPT services across the country are involved in. And hopefully that will then enable people to pick up kind of who's doing what and make links to other people. So thinking a little bit about the specific IAPT long-term conditions program in relation to chronic pain. And I was involved in the IAPT national expert reference groups that developed some of this work as a person working in IAPT and also with expertise in pain. So people can blame me for some of it as well. And what IAPT did was to think very carefully about some of the major categories of patients that might come into IAPT LCC services and think about how we would prepare the IAPT workforce for that and how we would collect information about those and what particular information would be useful to collect. So to begin with, it's important to recognise that in IAPT we usually use a problem descriptor, which means how we label that particular person's difficulties. And in the case of pain, this is usually their anxiety or their depression, because we don't see pain as the primary thing that we're treating. We're treating the anxiety or depression in the context of chronic pain. And this is true also for how we view diabetes or cardiac conditions, etc. The IAPT service is helping with the comorbid mental health difficulties that are associated with musculoskeletal problems or pain for many people. In order to think about who in the IAPT workforce we would skill up, we had developed curricula and competencies in each of the major areas of long-term conditions with specialists from those areas in order to develop a training scheme for people. And in chronic pain, we were focusing on the work of our Step 3 workforce. So those are our qualified psychological therapists, CBT mainly, where what we were saying was that if we have people we're treating for chronic pain within our IAPT services, normally we'd be expecting this to be Step 3 practitioners that were delivering that because of the nature of the type of problems that people were experiencing. So in our thinking, originally, that's where we were doing. And thinking about that, IAPT tries to think about using evidence-based approaches. We know for people with chronic pain that actually multidisciplinary approaches are most effective. So we would expect that the IAPT interventions would be being done where appropriate as part of an embedded multidisciplinary approach, addressing areas like exercise or work function, etc., at the same time, so to provide the best results. However, it's also possible for people who have musculoskeletal problems to experience a depression or anxiety problem independent of the pain or connected to the pain, where an individual treatment approach would be useful as well. And thinking about how we would measure whether that was effective or not, Ursula mentioned that there's a detailed set of outcome measures that the IAPT practitioners collect on every person at every single appointment. So that's called sessional outcome measures, and that means that, as Ursula said, 98% of people going through IAPT services, we know how they've done, because even if somebody stops treatment prematurely, you always have the last measure for that person, so you always know how they did. And this is important because services where you don't collect it like that tend to overestimate the value of that service, because the people who drop out aren't included in the measures. It's only the people who complete that you have outcome data for. And as part of the work preparing this, we also worked with a wider stakeholder groups and people who are interested in pain, and developed a document that covered what the IAPT long-term conditions and pain pathway should be looking like that. And that's actually covered there with the link, so that people who want to go and find out more can go to there and look at what's written about it. So that's the kind of background to IAPT and pain. I'm now going to just talk about our experiences of developing a pathway within Buckinghamshire. And this has got two stages. I'm going to have two slides. The first stage is what we've been doing over the last 2 to 3 years, actually integrating our chronic pain and fatigue management service with our IAPT service. And the second stage I'll come on to is our future thinking about getting the whole MSK pathway redesigned. So I mentioned that I had the advantage of the fact that I was responsible for both the pain and fatigue service and the IAPT service. So that probably made my job a little easier, in that when I was thinking about organising and designing it, I would go and talk to myself about it and say, oh yes, I think that would be a good idea. But I did have to do a lot of work between the two organisations, because the pain service was delivered through our local hospital trust, Buckinghamshire Healthcare Trust, and our IAPT service was delivered by the local mental health provider, which was Oxford Health Trust. And it was quite a difficult issue to think about how you could get two organisations to co-deliver a service. And what we offered from the IAPT service was to second IAPT staff through into the pain and fatigue management service, so that they could work in an embedded way with the multidisciplinary team that was already in existence. And the multidisciplinary team was psychologists, occupational therapists, physiotherapists, assistant psychologists, and then at wider links are pain doctors and nurses as well. And the idea there was that we should really be putting the IAPT service workers in with the most expert part of that service and strengthening the multidisciplinary provision. But we also thought that it would be a really good idea, because pain and MSK conditions are so common, that we thought about the other way. What about the people who are coming into IAPT services who have pain? How well are we meeting their needs? So we also have seconded over a psychologist for one session per week into our IAPT service from the pain and fatigue management service, with the idea that they provide supervision, training, advice, so pain expertise in to strengthen the IAPT workforce. All of our IAPT workforce in Buckinghamshire that are qualified have to go through the long-term conditions national training programme. So they've all had some training about how to work with people with pain. Although the long-term conditions training programme is relatively brief, and for pain conditions, that would just be 1 day of additional training. that's why we see it as really quite important that we've got some expert ongoing supervision and training provided into the service, because you're not going to have thought through all the issues. So I've written out here a diagram really showing how we've organised the pathway and how we've linked IAPT in. So this is really our pathway for people with chronic pain coming into pain management services. And I've really put into that the bit about where we've added IAPT in to strengthen up that. So we had a really well-established chronic pain and fatigue management service operating across Buckinghamshire, providing multidisciplinary chronic pain management groups, but with very little resource to provide any individual psychological therapy for people who presented into our service, for example, who had problems with PTSD, for example, alongside their pain. And normally we would just have had to refer those patients out into mental health services in order to get them treated. And that often meant that we would have to kind of have a whole disruption around which do we do first, how do we actually manage this, how do we communicate between the services, and people themselves had this sense of kind of jumping between organisations, not actually getting all their problems dealt with in one place. So within the service, referrals would come in from a wide variety of sources, from GPs, from consultants. Mostly that will be rheumatologists, anaesthetists, but other broader groups as well, neuro rehab consultants, etc., and health professionals, physiotherapists, nurses, etc. Lots of referrals from them. And the service was taking in referrals up until the last few years. It was commissioned just to treat about 200 people a year, but we've expanded the service so that we now receive about 800 referrals. This is with the same resource, I should say. And so one of the ways we've dealt with that is to kind of develop a step care model within our pain services as well, to make sure that we could use our resources most efficiently. So all people coming in initially are triaged, and for people with pain, they'll be offered a pain management information workshop. And the idea of that is that they'll get a chance to come along and learn about what the pain management services can offer, to think about the range of different treatments that might be available, and to make a choice themselves, and we make this a conscious thing, about where they want to go next. So that works very well for a lot of people and really helps people to think about what they're doing. Some people just need that. Some people actually can't even cope with that, and that's a really good indicator for us. If they can't cope with the workshop, they're going to struggle to cope with the pain management program as well, and maybe need to think about other ways. I should say I'm on the hospital route, so then what happens then is that if they can't manage to come in for one of those workshops, we would offer alternatives of telephone triage or face-to-face triage for people. So that the kind of alternative ways, because some people, for example, those who speak no English, they're really struggling in the workshop, then we actually can offer individual appointments for them as well. And then following on from that, we would then lead into an interdisciplinary assessment, and everybody following that comes to a formulation session where we think about developing a shared formulation with them and a treatment plan. And within that interdisciplinary assessment, that could be a physio, an OT, or a psychologist. Sometimes it's more than one discipline, but the team has worked together very extensively over many years and kind of developed that shared expertise that initially we didn't have. And we've integrated our IAPT workers into that level as well, so that they can actually be involved in some of those assessments, but they have needed to kind of go through that same additional developed training to do interdisciplinary assessment as well. And going on from there, one of the things that we might offer for people would be a kind of low intensity type of treatment. So this is sort of analogous really to IAPT in that we have a stepped approach. Low intensity treatments could include offering them a digital pain management program as a program called Pathways Through Pain. We've been running a local evaluation of that over the last 5 years, and we have treated a large number of patients using that digital program. We've recently published the data on that in the British Journal of Pain for anyone who wants to see how that digital program's gone. And that, as a result of that evaluation, the program has also been included as one of the recommended NHS programs, which has got some evidence behind it as well. So that's effectively a digital version of the pain management program, which we support with assistant psychologists. We also offer guided self-help treatments individually for patients following a structured, well-established evidence-based guided self-help model, pain management plan. And we do offer for people the chance really to do that either as face-to-face or on the telephone. For some people, that's better for people. And the other thing that we're offering, and this is what our IAPT worker is doing. So remembering this is step 3, qualified psychologists from the IAPT service who are coming across. They're able to offer individual psychological assessment and treatment for people who have comorbid anxiety or depression with their pain, who would be better treated as part of a multidisciplinary team approach. So they may well decide that actually this person really doesn't need the pain management team to work on their particular mental health problem. They could really benefit from some of the wide range of other services that the IAPT provides. So for example, our IAPT service provides a mindfulness long-term conditions program, so we could actually access into those programs. Or they would say, well, actually this person needs the pain management program, or this person could do with some individual psychological therapy. Maybe we'll actually look at addressing some of the aspects of their depression, and then they may go on to a pain management program or may never need a pain management program. So we have clinics operating each week for individual therapy provided by the IAPT service. They're supervised by the clinical psychologist working in the pain team. They're delivered in the pain team building, and the psychologists attend the multidisciplinary meetings. So really, for all intents and purposes, they're part of our pain MDT, although they are employed and paid for by IAPT. And then we have our pain management program, ACT-based pain management program, which is delivered jointly by the multidisciplinary team. And we also have our IAPT workforce participating within that as well. All people would then also go through a review and follow-up process from each of those different interventions. And they may go from one to another. So they may do a guided self-help, and they might then go on to a full pain management program or some individual therapy. So that's the current situation. And now I'll tell you a little bit about the future. This is my last slide. And within Buckinghamshire, what we've been thinking about is, well, okay, let's go a little bit further than this to think about the whole MSK pathway. I mentioned that we've been working with a digital program, and the digital program we've been doing with our local independent sector physiotherapy provider, who provides the first stage physiotherapy within Buckinghamshire. And the physiotherapist would identify people who might be suitable for the treatment and then pass them over to us to look to see if they were or not. So we'd already started to establish these really good working relationships with the physiotherapy services. As I mentioned, we're closely linked as a pain management program to the local pain clinics and anaesthetists. And I've worked in rheumatology for about 25 years as well. So we've got close links with our rheumatology colleagues. So all of these people already knew each other, but we were working in still a very kind of siloed way, sort of passing referrals between ourselves. And thinking about that, we felt that really what we weren't doing was providing the best, NICE approved, evidence-based treatments for people, particularly for people with pain. We weren't really giving people fast access to combined physical and psychological programs for people at an early stage. So you would get to the pain management program usually with an average of 10 to 12 years since you developed your problem, and often when you'd already been through 4, 5, 6 different other specialities before you got to us as well. So we're very much a last point, rather than it actually being something that would be an early thing we'd do once our physiotherapist colleagues have said, actually, we feel that the straightforward interventions haven't worked. We need to be thinking a bit more about a multidisciplinary approach. So we've been redesigning the entire MSK pathway for the last couple of years. Orthopedics has taken up a lot of the thinking around that, and more latterly we've managed to get pain on the agenda for that. So we've had Buckinghamshire is an integrated care partnership. It was an ICS, one of the early ICSs. So this is part of our integrated care partnership working, where we are jointly developing with our CCG, with our independent sector, with our hospital trust and our mental health trust, a joint pathway for pain, MSK. And we've had a working group working on this, developing this new pathway. Very lucky to have had GP representation on it, rheumatologist on it, anaesthetist on it, and with support from our ICP to project manage the whole thing. It's really sort of accelerated in the last few months since we've had that project support. And this is one of the outputs so far, which is the new pathway we've developed, which we're hoping to get business case and funded for into the next financial year as part of that MSK redesign. And we're just starting to look at piloting some of the pieces of work in it. So particularly notable things will be familiar to lots of people that we're trying to think through kind of the potential impact of the first contact practitioner, physiotherapists next year coming into our PCNs. And we're expecting that primary care will be looking to skill up our primary care colleagues to early identify people who may have a likelihood of developing chronic painful conditions. We've been looking at developing some simple new guidance and tools for our practitioners to do that. Then coming into our new advanced pathway, where early on our physiotherapy provider would look to actually have a specific pathway for these people. Those who we've identified may have yellow flags, so the high risk of developing increased chronicity, disability. And then if those people aren't suitable for more individual physical therapy, then passing them to our combined early multidisciplinary program, physiotherapy, psychology, anaesthetics, or rheumatology. We haven't decided which doctor it will be at the moment. And we're hoping that they will run a range of programs, both individual treatments and CPP, combined physical psychological therapy programs. And then following on from that, hopefully a lot of those patients will have a good outcome from that. But some people with more complex problems may then move up to our new integrated specialist pain team that we're hoping to develop, which kind of will bring together our pain management programs, our existing pain clinics, and other specialities into a highly experienced and expert team who can provide more intensive programs and a range of other treatments for people. And then a very important part of that is also about how we step people down and out of the system. Sometimes those people might actually be people who get stuck in hospital services and keep going round and round, don't know what they're doing with it. And we're hoping that this will actually pick those people up, avoid a lot of the duplication that's going on currently in our services, where people will kind of go to the orthopedic pathway, then go off to rheumatology, then they might see a neurologist and then an anaesthetist, and eventually come to pain management. Very frustrating journey for people. So that really is our future plan, and we're hoping that within that, the IAPT services will play a key role. So we're seeing the IAPT services as being closely involved at this new early intermediate care level, providing the CPPs with support and advice jointly with our physiotherapy services and with input from supervision from our specialist psychologists working in pain and our anaesthetists and rheumatologists. Thank you very much.
Thanks, John. So I'm now going to invite, John can stop sharing slides, and I'm going to invite Johnny to present. Johnny, sorry, we've also got quite a few questions coming in, so if you can try to make sure we've got 5 or 10 minutes for discussing some of these at the end. So I need to share Johnny's slides. Sorry. Okay, Johnny, so hopefully people can now see Johnny's slides. And yeah, we've got various questions coming in that I think merit a bit of discussion, including particularly people looking for advice on how to do integration and what to do if integration isn't happening. But anyway, Johnny, over to you.
Okay, hello everyone. I'll try and be quick then, because I appreciate people are probably more interested in getting their question answered than hearing me talk. You can't see me on the video, I'm afraid. I'm calling by phone. So very briefly, my name is Johnny Wilkins. I'm a CBT and EMDR therapist and also a registered mental health nurse. And I work for the TalkWork service, which is the IAPT provider down in Devon. So we cover the whole of Devon, apart from the city of Plymouth that has a separate service. Okay, so if you could move on, Sue. So very briefly about us, we're the IAPT provider across Devon. We're now 10 years old. It's our 10-year anniversary this year. 3 years ago, we became one of the first wave sites that John talked about and Ursula talked about for the IAPT LTC expansion. So we were one of the initial 21 sites that piloted and rolled out specific long-term condition work. The way that we chose to do it in Devon is historically we have 5 IAPT teams, TalkWorks teams within Devon that cover each of our localities. We're a huge county. We think we're possibly the biggest IAPT service in the country. So we created a whole separate 6 team called the Talking Health team, which is the team that I manage. And my team operates across the whole of the county, apart from Plymouth. So we specifically set up a team and brought together a group of clinicians to exclusively work with people with common mental health problems and long-term health conditions. So I think in some IAPT areas, what they've done is they've expanded the existing services, and they maybe have individuals within existing services that specialise within with working with people with long-term health conditions. Within our service, we decided to create an entire team that was dedicated to that. So I have a team of now around about 30 clinicians spanned across the county who exclusively work with people with common mental health problems and long-term health conditions. We sit within now 1 CCG, previously 2, but they've now merged to become 1. We do have 4 acute hospital trusts locally, so we have 4 separate pain management and MSK and rheumatology services to liaise with. But for the purposes of this presentation, I'm going to focus on one of those acute trusts. So if you could move on, Sue, to the next slide. So about 2 years ago, we started setting up pain management pathways with existing services, and I'm going to focus on our services based in Exeter, out of the Royal Devon and Exeter Hospital. The service so far has received from the Exeter service has received about 120 referrals so far, but this doesn't include people that will have self-referred, so some people will be referred directly by healthcare clinicians, but a large number of people are signposted to self-refer. So it's 120 direct referrals plus referrals from the self-referral pathway. So if you could move on again, Sue. So this is a slide demonstrating our pathway. So essentially what we did here is we plugged ourselves into the existing pain management pathway. So this is particularly our specialist pain management and rehabilitation service. I'm going to talk a little bit more about rheumatology and MSK separately. But this was our existing pain service, who would receive referrals from GPs and consultants and community physios. They have then their own MDT, which essentially is made up of physios, occupational therapists, and specialist pain psychologists. They would previously have an initial assessment for a patient, that have an MDT discussion, and then within their service they had a range of treatment options, which ranged from one-to-one work with a physio and OT. They had a 5-week, twice-weekly pain management program. They had a specific program for people with fibromyalgia, and a compassion-focused pain group as well, in addition to individual work potentially with a pain psychologist. So they had around 5 different options that sat within the pain service. What we did in integrating and becoming part of the service is we plugged IAPT in to their existing offer. So what happens now is when patients come through and having had an initial assessment within the pain team, usually done by a physio and OT, at that MDT discussion, IAPT, so our service, the Talking Health service, is now a treatment option within that pathway. So if it's thought that our service, Talking Health, might be an appropriate intervention, the link at the moment is the lead pain psychologist within that service will send a referral through to me as the team's clinical lead, and we will triage those referrals, and then we will bring people into treatment within our IAPT service. So we have both step 2 treatment, that's a psychological wellbeing practitioner, low intensity therapy, and we have step 3, which are qualified psychological therapists, and we have both of those workers co-located physically within the physio department within the pain clinic. And I think I'll talk a little bit more about this later, that's really crucial to the way I think that services can link up. So we essentially have expanded the offer within the pain service, and then there's constant ongoing liaison between myself and the pain psychologist. We meet up regularly to discuss how our referral pathways are going. There's often information sharing between the 2 services. And then if for any reason people who come into our service need further help than we're able to offer, we then have a step-up group into the formal pain psychology. So John talked a lot about step care. We try very hard to build the full range of step care into the pathways that we have. So step 2 and step 3 sitting within IAPT, within Talking Health, and step 4 being delivered by either health psychology, clinical psychology, or secondary care mental health services. So if we move on again, Sue. So specifically, in addition to the pain management rehab team, we also have very good links with rheumatology, which is a separate service here in Exeter. So what we do in rheumatology, which is something that we do in other pathways that we work with, is that we now attend their medical MDT. So a member of my team sits alongside consultant rheumatologists and nurses and other health professionals, and as part of their general MDT where they're discussing the medical aspects of rheumatology patients, there's also an option for their clinicians to bring patients that they've seen where at any point in their pathway where they might be concerned about their emotional health. And then we will take referrals via that MDT and provide feedback about people that we're working with via that MDT. And we're hoping also to be physically co-located in the rheumatology department. We're not quite there yet, but we're on the way to doing that. We also have a similar setup with our separate CFSME service. So we have co-located clinical space with our CFSME service. We have a similar referral pathway, and we will have some inter-service learning around us attending and potentially being part of the group program that they run, and vice versa. So within Exeter, there's kind of, I guess, 3 branches that's relevant to what we're talking about today: the specialist pain service, the rheumatology service, and the CFSME service. So if you could move on again, Sue. So the next stage is, I know John's last slide, he shared a slide about how they're hoping to develop their pain pathways in books. We're about to go through the same process together. So we're here in Devon using a quality improvement process, which is run by the Flow Coaching Academy. So this is essentially a quality improvement process that was set up in Sheffield, and it's a process that's designed to bring people together from cross systems, cross networks, cross organisations together into what they call a big room. So what we will be doing, this is just started in the last couple of months. If you could move on to the next slide, Sue. Yeah. So it's a quality improvement methodology to drive change. So it's something we've done very successfully with the gastroenterology department here in Exeter. And essentially, once a week, every single week, we will be bringing together people all of whom have a stake in working with people with pain and MSK presentations. That will be people from pain service that I've talked about, rheumatology clinicians, CFSME clinicians, GPs, representatives from health psychology, ourselves being IAPT Talking Health, patient representatives and third sector organisations. And it's really going back to exactly the same thing that John mentioned, is that we often find that people who end up being seen within pain management services and then referring to us have often had a long journey through a variety of different medical services before they get there. And we're trying to bring those services together and understand how we might be able to intervene earlier in someone's journey. And our service, similar to John said, will be looking to try and access and screen patients for emotional health problems and intervene earlier, so that we don't see them at the end of their pathway when they're perhaps disillusioned with the NHS and have been turned away and passed around from department to department. Okay, so if we move on to the last slide, I'll try and finish up relatively quickly. So I'm just going to finish with some top tips, and I'm aware that some of the questions are about how do you actually go about doing this. So first thing to say is IAPT sits within a step care model. The whole system works best when all steps are available. So we work very hard in all the pathways that we work in to have steps 2, 3 and 4 available. So steps 2 and 3 are us. That's the IAPT service. We're a block contracted service here in Devon, so there's no cost to any medical services about us providing therapy for patients that they're seeing. The way health psychology is commissioned in Devon is a little bit different depending on which part of Devon you're in. But the system works so much better where IAPT and Step 4, and for us I mean health psychology, work well together. I think that's hugely important. So the links with health and pain psychology have been absolutely crucial for us to make this work. A really crucial thing, I know one of the questions has been about how do you actually get this going? How do you get this kind of integrated work happening? You can't integrate with people that don't want to be integrated with. So it's absolutely crucial that you have interested and engaged physical healthcare clinicians that can make this work operationally on the side of physical healthcare services. Sometimes you need to work hard to get that engagement. Some people, for some people, there's a natural interest. So we're really lucky here in Exeter within our pain and within our rheumatology pathways. We've got some really interested healthcare clinicians that see this as part of their role anyway and want to engage with us. But sometimes it is about a bit of cold calling and knocking on people's doors and asking if you can come and talk to them about the benefit of bringing a mental health service alongside their physical health care service. Co-location and MDT presence make a huge difference. I can't stress enough how just having a referral pathway, like the slide I've got with lots of arrows on, doesn't work if you don't see people and never talk to them. Having people in offices next to one another where they can develop informal links and have informal conversations and pass on informal learning between the teams is really, really helpful and really, really crucial. And I think it's more important than having a fancy slide with lots of arrows on. The personal relationships between mental health staff and physical health staff is what really makes this work. I know one of the other questions was also about systems and budgets and how does that work. The truth is it doesn't work unless people are willing to work across systems and across budgets without being protected. So I would say there are 3 ways you can make that happen. One is you can get the CCG to commission it, so you can get the CCG to say to physical healthcare services as well as mental health care services, we're going to commission you to work together. The second way you can do it is you can get executive buy-in from hospital-based services. So if you can go to the top and pass the message down through their services that they see it as a priority to work alongside mental health services, that works. The third thing that works is bypassing both of those two and just simply going in at the departmental operational level and finding those interested, engaged physical healthcare clinicians, and then you just make it work. Some of the issues that we've had about budgets, well, we speak to the clinicians, we make the case for this working, they speak to their local managers, and permission is just given, and we use rooms for free, and we have that integrated working. And if you can convince people that it's worth doing on the ground, you can just make it work. We can work together if we choose to. It's about working as a national health service instead of working as separate organisations with separate priorities and separate budgets. And my final point, as I said there, is talk and meet regularly. If you continue to talk to people, don't just have pathways on a page with arrows and referral pathways. If people could be in the same place at the same time and regularly talk to each other, it makes a huge difference. Okay, Sue, pass you back over to you.
Great, thank you very much. And I think you have rather neatly begun to address quite a lot of the questions that are coming through, because a lot of them are about how do you get things integrated, and what do you actually do to make sure that there are those links. And I think Arma would agree that having all of those steps available and not just IAPT in isolation is really critical. So I think your final slide has probably addressed quite a bit of that. People have also been asking if they can have access to slides and links to the various resources, and we will try to put all of that together into the email that we send you afterwards, so that you can access some of the things that people have been referring to. Just having a quick look if there are other. John, I don't know if there's anything you want to say about how you actually get to the integrated service that you have. Have you got anything to add to what Johnny said?
I think what Johnny said is a really good summary, and what's important is that a lot of those top tips are all embedded in the guidance for IAPT services, so that none of that should be unusual. It's written down how we could go about doing this, in the principles are all there. What we found on the ground, though, is that sometimes people don't operate according to that as well. So there sometimes can be difficulties. And I think that when friction arises, it's important to have ways of being able to resolve that friction as well. And I think thinking about who within your local area helps to resolve that. Certainly locally, we've found that thinking about the commissioners having a particularly useful facilitating role. Certainly senior managers, chief execs have played an important role for us in terms of when things have got stuck, yeah. And then more latterly, our ICP colleagues have been really helpful. But probably the most important thing for me in terms of getting things unstuck has been people's voices. So the experience of people who've been through the services talking about what they want, and being able to say, we don't want it just done the same way as you've always been doing it, we want it better. And that's quite powerful.
Okay, that's great, thank you. There was a question about patients who are seeking alternative treatments outside of the NHS, potentially being signposted back in. So do you have to come into your services through a GP who you may already have lost confidence in, or other ways can you self-refer into your services?
IAPT is a self-referral service, so anyone should be able to refer into their local IAPT service, and there's full coverage in England of all areas should have an IAPT service here. But that's a bit different when you're talking about integrated services, because if the IAPT service, essentially, if you're working in a fully embedded way with an existing pain service, then your entry points to that are going to be for the pain service. But people could quite easily, with chronic pain, self-refer into our IAPT service, be identified as actually having the pain needs as well. And then our IAPT service would make that transition with them across into the pain services. So there can be some useful hand-holding that can support people through. We do within our IAPT service always expect, though, that people, when they come into our IAPT service, we say to them, we will keep your GP informed about what's going on as well. So, you know, that's important because we don't know all the different things that might be happening for that person as well.
Right, and do you have anything to add to that, Johnny?
I guess just to reiterate what John has said, self-referral is absolutely central to IAPT. We facilitate that here. One of the things that we're looking at doing, because the TalkWorks presentation that you just saw is a relatively new rebrand for us. We used to have a different name. We've just recently become TalkWorks, and we're looking at developing marketing materials specific to different medical pathways. so that can be displayed in certain areas. So we're just going to do something with rheumatology, and probably similarly with pain. So to encourage very specific groups of people to come and self-refer, so that people don't have to go via their GP or via their consultant.
Okay, great. And there was one more that I was just going to quickly come. Oh yes, there's a question here about what about areas that don't have a pain service? Any thoughts on that?
Okay, that's an interesting idea. There are pain services, I think, available in most parts of the country, but obviously that might mean people haven't got it in their local area. They've got the person's referred out to things. And I suppose my thought about that would be, first of all, make sure that you really haven't got a pain service, or that there isn't one that's available through that. And there are, I think it's either come out or it's coming out very shortly, the British Pain Society is publishing the latest list of all the pain management services across the country on their website. I think it might already be there, but I'm not sure. And that's a good place to go to that directory first and really make sure that you haven't got one. And I suppose I would be saying that if you haven't got access to a multidisciplinary pain management service, I would be talking to your GP about discussing with the CCG how I can be sent out to one as well. Because if somebody needs that service, then that is an evidence-based treatment approach. Within IAPT, the danger could be that IAPT services could be seen that they're going to, if you like, replace or do something that actually is missing. And I think we're not talking about that. We're talking about IAPT services adding to the offer, but they're not there to provide a multidisciplinary pain management program. They don't have all that expertise.
Okay, that's really helpful. And I think the lack of pain services is quite an issue, and it's something that has been raised with ARMA, and the ARMA is going to be looking at. So do keep an eye out for reports we're holding a round table on pain at the end of next month, and there will be a report on that coming out before the end of the year. So look out for that. Because
I might say one of the issues is not just an issue about whether you've got a service or not, it's that the capacity of those services.
Yes.
But actually the amount of people with pain who could benefit from these approaches is so large that most, though you may have a service, it may just not have the capacity to see everybody.
Yeah, and the waiting times for some of them are astonishingly long.
Yeah.
But anyway, thank you very much, everybody, for joining our webinar, and thank you to all of our presenters. I hope we've covered most of the kind of top line issues raised in the questions. We might pick up one or two of those in the email that we send out afterwards, and we will try to send you as many links to as many useful materials as possible. So thank you everyone for that. And